Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and today's topic is esophageal cancer. Now I want to start off by saying that this is for patients, so I'm going to keep it as simple as possible. And I also want to warn you, esophageal cancer is a little bit complicated because there are many different treatment options. So keeping that in mind, I'm going to help you through it, and at the end I promise you we will tie it all in, okay? So let's get started. So let's start off with an overview of everything we are going to cover. We're going to start off with how to make a diagnosis, then we will go on to risk factors, followed by staging, then treatment options, then we're going to go over biomarker testing, which is very important and you really should know this. And as the last bullet point here, I have take notes. And what I mean by this, I highly recommend that you grab yourself a piece of paper and a pen. And throughout this presentation, I will be telling you the questions that I would have if I was a patient with esophageal cancer. Okay, and let me remind you, I am a cancer doctor, and these are the questions that I would have. So in my opinion, these are very pertinent questions and the ones that you should really know. So just a little reminder, this video is for educational purposes only. I am not providing medical advice. So let's start off with the anatomy, and believe me, you need to know this in order to understand the treatment options, okay? So first of all, when you eat, food travels down our esophagus. This highlighted organ is our esophagus. So food travels down our esophagus into our stomach. Now, our esophagus, from an oncology standpoint, we divide our esophagus into two. Our proximal esophagus, which is closer to the mouth, and our distal esophagus, which is closest to our stomach. And what's important about this is about the first 2/3 of the esophagus, what we call the proximal portion, the most common cancer that arises in this area is a squamous cell carcinoma. Whereas in the distal segment, okay, the closer to the stomach, the most common cancer in this area is an adenocarcinoma. You need to keep this in mind because depending if you have an adenocarcinoma or a squamous cell carcinoma, the treatment options may differ. Okay, so that's the first thing I want you to keep in mind. I also want you to keep in mind that around our esophagus, in this area here, you will find lymph nodes, and lymph nodes are part of our immune system. And the reason you need to know this is that esophageal cancer begins on the inside of your esophagus, and then it travels through the walls of the esophagus, and then it will spread to lymph nodes. And eventually, from the lymph node, it will spread to the rest of our body. And that's important because you need to know the pattern of how esophageal cancer likes to spread. Okay, so keeping that in mind, let's move on to the next slide. So let's talk about diagnosis. In other words, how do we diagnose esophageal cancer? Well, chances are you developed symptoms first. Either you could not swallow correctly, or you had pain, or you had a lot of gastric or acid reflux, whatever the case may be. Chances are you were sent to a gastroenterologist and they performed an endoscopy. And this is when they pass a camera through your esophagus and we are able to visualize the inside of your esophagus. And chances are they found a mass inside your esophagus and a biopsy was taken. So a little sample was taken and this was analyzed. Now, as I already mentioned, the two most common cancer types in your esophagus is either an adenocarcinoma or a squamous cell carcinoma, okay? The important thing here is to exclude another histology. And what I mean by this is there are other types of cancer besides an adenocarcinoma or a squamous cell carcinoma that you can develop in your esophagus. But I have to tell you that 99% of the times, it's either gonna be an adenocarcinoma or a squamous cell carcinoma. So this is the time you should find your pathology result and find out, do you have an adenocarcinoma or a squamous cell carcinoma? Because this will definitely have treatment implications, okay? So the first question that I would have is, what cancer do I have? Is it an adenocarcinoma or a squamous cell carcinoma, and also make sure that you don't have some other type of cancer type, which would be very, very rare. All right, now let's move on to staging. And this is when we will perform tests to try to figure out how advanced your cancer is, okay? Very important, because this will also have treatment implications. Now, the first thing we will order is either a CT scan or a CAT scan of your chest and abdomen, or a PET scan. And the whole idea here is to take pictures of your body to try to figure out, is this cancer localized to the esophagus, or has it spread to another area of the body? Because if you recall, during the anatomy section, I said that this cancer in the esophagus will start inside the esophagus, will travel through the walls of the esophagus, then to lymph nodes around the esophagus, and then to other areas of the body. So we want to look to see, can we find this cancer somewhere else within your body? Okay, now the other test that we can perform is what we call an endoscopic ultrasound, or EUS. And this is a relatively important test. And this is at the time that they do your endoscopy, okay, that we're putting that camera down your throat. We can also use an ultrasound probe. And the important thing here is, through an endoscopic ultrasound, we can try to figure out how advanced is this cancer within your esophagus. So this ultrasound can see through the layers of your esophagus, how deep is it penetrating your esophagus. And it can also look for lymph nodes. So it's a very important test. And my question to my doctor would be, for example, what imaging tests are we going to perform? Is it going to be a CAT scan? Is it going to be a PET scan? And are they going to perform an endoscopic ultrasound? Because ultimately, the main question we want during staging is, what stage cancer do I have? Do I have a localized esophageal cancer? Okay, it's just there in one area, or has it spread? Has it gone to another area of my body? So in other words, I would have an advanced esophageal cancer. All right, so now let's go over risk factors. In other words, what could have provoked this cancer? Well, in general, for squamous cell carcinoma, by far the most common risk factors is long time smoking and heavy alcohol consumption. Whereas an adenocarcinoma is usually due to heartburn. So we call GERD, or acid reflux. Another thing is that constant acid reflux could damage the lining of our esophagus, causing what we call Barrett's esophagus. So these are the most common risk factors. But I can tell you that I have many patients with esophageal cancer whom have none of these. In other words, I call it just bad luck. So don't think that just because you don't have any of these, you are not at risk for developing esophageal cancer, because we are all at risk for developing this cancer. So if you've been diagnosed with esophageal cancer, chances are you're going to see these three doctors, okay? The first one is a surgeon, because surgery is a very important part of the treatment of esophageal cancer, as well as a hematologist oncologist. That's, for example, what I am, and we provide chemotherapy and immunotherapy. And the third is a radiation oncologist, and those provide radiation. So I don't want you to confuse a hematologist oncologist, also called a medical oncologist, from a radiation oncologist, because they provide radiation, okay? So now you know. All right, so I'm constantly coming out with cancer-related educational videos, and as you can see, it's really patient-oriented. So consider subscribing, hit the like button, and share the video. So let's continue. All right, so now we're going to go over treatment. And I have to tell you, esophageal cancer is complicated. I said at the beginning, and the reason it's complicated is because there are many treatment options. So this is a very hefty discussion that you will have with your medical oncologist, your surgeon, and your radiation oncologist, okay? So just to give you an idea of the different treatment options that you may have. First of all, surgery. Maybe surgery followed by chemotherapy and possibly radiation as well. Maybe chemotherapy first, followed by surgery, followed by chemo. Sometimes we give chemotherapy and radiation, and depending on the outcome, you may have surgery afterwards. Sometimes you may have what's called definitive chemoradiation, where we say to ourselves, you know what, we're not going to take the patient to surgery. We're just going to give the patient chemotherapy and radiation. Another option is chemotherapy with or without immunotherapy only. It really depends on the age of the patient, the performance status. In other words, how strong is the person? Because let's face it, if you're older, more debilitated, maybe you have multiple medical issues, maybe you have a very weak heart, then you might not be a candidate, for example, for a very aggressive surgery. It also depends, where is your cancer located? Also the stage. If you have very early stage disease versus metastatic disease, of course the treatment will differ. And the histology. So believe it or not, as I already mentioned, if you have an adenocarcinoma, the treatment may vary compared to a squamous cell carcinoma. And that's why you need to know which one you have. All right, so let's continue with treatment. All right, so now as far as treatment is concerned, let's concentrate only on early stage disease. So we're going to go over local esophageal cancer, and then in another slide, we will go over metastatic or advanced esophageal cancer, okay? So the first thing is, it doesn't really matter if you have an adenocarcinoma or a squamous cell carcinoma. If you have, notice I put here, very early stage esophageal cancer. So let's say you're one of those fortunate enough that we detected the cancer so early that it is a tiny speck in your esophagus. It's a tiny little cancer in your esophagus. Well, there's such a thing as an endoscopic resection. And this is, at the time that they do your endoscopy, they might be able to cut that little cancer out, remove it. But in order to do so, it has to be extremely early. So one of the questions that I would have for my doctor is, am I a candidate for an endoscopic resection? Okay, that would be one question that I would have. Now, if it's a little more advanced, it's not that tiny speck, okay? It's a little more advanced, but it's still local. It's still only within my esophagus. It has not spread to another area of my body. Then surgery, what we call an esophagectomy, is another option. So obviously, my questions would be, am I a candidate for an endoscopic resection? And number two, can I go to surgery, and is that enough? Can I avoid chemotherapy, radiation, and all the other treatment options that we have, okay? All right, now let's talk about local adenocarcinoma. So now we're going to talk about adenocarcinoma, and then in the next slide, we will go over squamous cell carcinoma, okay? So if you have an adenocarcinoma, this pertains to you. So as I said, we have many options. And again, this is a discussion you have to have with your oncologist. But the preferred option that we do nowadays is we will give you chemotherapy first, followed by surgery, and then chemotherapy after surgery, okay? And the whole idea here is providing chemo to try to shrink up the disease as much as possible, then removing the remaining cancer with surgery, and then giving you chemotherapy again to see, hopefully, if you have micrometastatic disease or just tiny cancer cells that were left behind, hopefully that remaining chemotherapy will kill off that cancer cell. So chemo followed by surgery, followed by chemo. And that's, like I said, one of the preferred treatment options that we provide now for an adenocarcinoma. Now, the chemotherapy that we usually use in this scenario is called FLOT, F-L-O-T, and each letter pertains to a chemotherapy, okay? So the F stands for 5-FU, okay? The main side effect of 5-FU is a little bit of diarrhea. It can cause mouth sores. It can reduce your appetite, a little bit of nausea. Leucovorin is pretty well tolerated. That's the L. The oxaliplatin is another chemotherapy. And oxaliplatin, you will hear it again in this presentation. Oxaliplatin has more side effects. Oxaliplatin is known for neuropathy. Okay, so the pins and needles sensation on your hands and feet. And there's a type of neuropathy which is called cold neuropathy. So for example, when you get oxaliplatin, you got to be careful touching something cold or drinking something cold because it can shock you. And it usually lasts for 1 to 2 days after you receive the oxaliplatin. Now, the other issue with oxaliplatin is once you receive a lot of oxaliplatin, you can get more neuropathy, okay? The pins and needles, and it can become quite debilitating. So your doctor will monitor you for this. It also causes other side effects like nausea, diarrhea. I mean, it can decrease your blood counts. So again, your doctor will monitor you for this. The last one here, which is the T, is docetaxel. And the reason it's a T is because the other name is Taxotere. So docetaxel is pretty rough. Docetaxel, it's a very good drug. It's called a taxane. And docetaxel can decrease your blood counts. So you got to monitor your white blood cells, your platelet count, your hemoglobin. It can also cause a lot of hair loss. It can also cause nausea, vomiting, diarrhea. So again, I have to tell you, FLOT chemotherapy is no joke. It's pretty rough chemotherapy. So if you've undergone FLOT treatment or you will be undergoing FLOT, brace yourself because it is no joke. Now I can tell you it's very good chemotherapy, and for esophageal adenocarcinoma as well as gastric cancer, a lot of times we use FLOT. Okay. Now, another option for local adenocarcinoma is chemotherapy and radiation first, followed by surgery. That's another option that maybe your doctor will recommend in your case. Now, for chemotherapy and radiation, the chemotherapy that we usually use in this instance is two drugs. One that's called carboplatin, which tends to cause nausea, vomiting, low blood counts. And we adjust it based on your weight, just like all these chemotherapies. And the other chemotherapy is called Taxol. The other name is paclitaxel. And this one causes hair loss, decreasing your blood counts. So again, we got to monitor your blood counts. So the other regimen besides carbotaxol is 5-FU, which we've already gone over, and oxaliplatin. So the combination of 5-FU and oxaliplatin. And I already mentioned the side effects to these. Now, I put another drug here. It's called capecitabine. Just know that capecitabine is oral 5-FU. 5-FU is given in the vein, while capecitabine is a pill. And similar side effects to 5-FU, but it also has another side effect that you need to know about, and it's a rash in the palms of your hands and the soles of your feet. It doesn't always happen, but you need to know about it. So if you're taking capecitabine and you start developing issues or a little rash or desquamation of your palms of your hands and your soles of your feet, it's the capecitabine, okay? There is a cream out there. It's called Udder Cream, which they state might help with that type of, they call it hand-foot syndrome, and that Udder Cream may help, and your local pharmacy should have it. Now, sometimes the other option is chemoradiation only. So for example, maybe you're older, maybe you're not a candidate for surgery. Sometimes patients do not want surgery. So in these cases, we may only recommend chemotherapy and radiation, and we're done. But I do have to tell you that as a general rule, just know that adenocarcinoma tends to benefit from surgery. Okay, remember I told you there are differences. And the take-home message here is if you have an adenocarcinoma of the esophagus, surgery tends to be very important. Okay, so keep that in mind when you're having that discussion with your doctor. And obviously, one of the questions I would have if I had a local adenocarcinoma of the esophagus is, which one of these treatment options is my doctor going to recommend and why? And like I already said, hopefully, if you're able to tolerate it, surgery is within that treatment algorithm, okay? All right, now let's go over the treatment of local squamous cell carcinoma, okay? So notice I'm saying local. This does not include metastatic disease. For metastatic disease, we will talk about in the next slide. So if you have local squamous cell carcinoma, then one treatment option is chemotherapy and radiation only. Notice how I said only because hopefully we can avoid surgery, okay? Remember I said for adenocarcinoma, we really want to try to go for surgery. Whereas for squamous cell, we might, on some occasions, avoid surgery. And the way we do it is we will send you for chemotherapy and radiation. And once you complete this treatment, a while later, usually a few months later, we will repeat an endoscopy and we will see, do you have remaining cancer cells left behind? And if we cannot find cancer cells, then maybe we will simply observe you from this point. Whereas if you do have remaining cancer cells left behind, then we will send you to surgery. That's one option. Now, another treatment option would be chemo and radiation followed by surgery. It really depends. Every case is different. Maybe if you presented with a very large tumor that, was only localized to your esophagus, your doctor might say, you know what, it was a little too large. I want to give you chemo and radiation, and we still want to perform surgery. So again, I'm just giving you general guidelines here. It's really ultimately left up to you and your doctor, because obviously they know the details of your cancer. And again, as before, the chemotherapy that we tend to use with chemo and radiation for esophageal is carboplatin and Taxol, which we discussed on the last slide, as well as 5-FU or capecitabine together with oxaliplatin. Now, as a general rule, just know that squamous cell carcinoma benefits more from radiation than adenocarcinoma. So remember, in adenocarcinoma, they benefit more from surgery, whereas squamous cell carcinoma tends to benefit more from radiation than adenocarcinoma does. Okay, these are just some general rules that we go over. But again, there are times we give radiation to adenocarcinoma, and there are times that we perform surgery for squamous cell carcinoma. Okay, so that's the discussion that you have to have with your doctor, and that's why at the beginning of the presentation I said it can get complicated. Okay, so a question I would have if I had local squamous cell carcinoma of the esophagus is, can I avoid surgery? Okay, because let's face it, nobody really wants major surgery. All right, now what about the treatment for advanced or metastatic disease? And it really does not matter if you have an adenocarcinoma or a squamous cell carcinoma. We tend to treat them about the same, except there are a few exceptions. And the exceptions tend to be there are some medications that we can use for an adenocarcinoma that we tend to avoid for a squamous cell carcinoma. But in general, if you have metastatic disease, the treatment of choice is usually chemotherapy, okay? Because think about it, if you have cancer that's advanced, in other words, it's in another area of the body, then why are we going to send you to surgery to resect that tumor in the esophagus where we're going to leave disease behind somewhere else in the body, okay? So chemotherapy tends to be the treatment of choice for metastatic disease, whether you have adenocarcinoma or a squamous cell carcinoma. And there are many different options. Now, I'm going to go over some of the more common treatment chemotherapy options that we use. The first one is FOL-FOX, called FOLFOX. And this is just a combination of drugs, for example, leucovorin, 5-FU, and oxaliplatin. And we already went over these previously. So we combine all of them. It's called the FOLFOX regimen. Fairly well tolerated, although it does have its side effects, and everybody's unique. Some patients tend to tolerate it a little better than others. Just as a general rule, the nausea, possible diarrhea, the mouth sores, the neuropathy, the cold neuropathy, as I mentioned, are very frequent with this regimen. The other chemotherapy regimen is called CAPOX, so CAPOX. And again, it's capecitabine, which is the oral 5-FU, and the oxaliplatin. Remember, we discussed the nausea, vomiting, diarrhea. We discussed the rash in the palms of your hands, the soles of your feet, called the hand-foot syndrome. And the oxaliplatin, once again, very important medication in esophageal cancer is oxaliplatin. The third chemotherapy regimen that we use quite often is called FOLFIRI. The difference here, it's the same leucovorin 5-FU, but instead of oxaliplatin, we use irinotecan, just another drug. The main side effect of irinotecan are GI side effects, diarrhea. It's a biggie for irinotecan and something you have to keep in mind. So if you're on an irinotecan-based chemotherapy regimen, you need to stay hydrated, okay? You have to drink a lot of fluids. And if you have a lot of diarrhea, let your doctor know. I put here ramucirumab and others. Just know that there are multiple treatment options. So a question that I would have is, what chemotherapy regimen will I be receiving? And once you know the chemotherapy regimen, you will know the potential side effects. Now, I do want to tell you, Everybody is different, okay? I have patients that we give them one of these chemo, for example, FOLFOX. We give them this chemotherapy regimen, and they will literally tell me, Doc, I feel great. I'm tolerating it super well. Whereas another patient will tell you, you know what, Doc, I'm not tolerating it as well. I'm having a lot of nausea or diarrhea or neuropathy. You know, the reason I'm telling you this is never compare yourself to another person, because a lot of patients tell me, well, my sister, my friend, my neighbor, they underwent chemotherapy and they didn't tolerate it well. They did horrible, so I don't want chemotherapy. Listen, you cannot compare yourself. Remember, what chemotherapy did they receive? What dose did they receive? What combination did they receive? And like I just stated, everybody is different. So you might be surprised. You know, I have a lot of patients that tell me, you know what, Doc, it was a lot better than I anticipated. So keep that in mind. The last thing that I want to go over here is notice how I put sometimes radiation. And what I mean by this is, think about it. If you have a large mass in your esophagus and it's preventing, for example, your ability to swallow, food stays stuck within your esophagus, well, sometimes we will give you radiation to that one area to hopefully shrink the tumor and improve your ability to swallow. Another example, maybe you had cancer that has metastasized to your bone, and this is causing a lot of bone pain. Well, we can give you radiation to that one area of the bone, and that will hopefully improve your pain level. It will improve your symptoms, okay? So that's why I put on here sometimes radiation. All right, now this is the last slide, and it's a very important slide, so I hope you're awake. And here we go. It's called biomarker testing. And this is mainly if you have more advanced disease, but it's important that you know that your cancer might express a protein or a mutation, whatever the case may be, that might improve your chances of responding to a specific treatment. Okay, I'm going to go over. You don't need to memorize these. I just want to go over them so that you understand what I mean. You might have something that's called microsatellite instability, MSI high, or you may have a high CPS score or high TMB or a high PD-1. If you have one of these, it will imply that you will likely respond to immunotherapy. So think about that. We have medications that may stimulate your immune system to attack your cancer cells, and we call that immunotherapy. Well, if you have these, you're more likely to respond to immunotherapy. Another example is the HER2 protein. If your cancer is HER2 positive, meaning you have that protein, you're more likely to respond to treatment that attacks the HER2 protein. And the same thing applies to each of these, okay? The NTRK, the RET, the BRAF. So you don't need to know them. What I want you to ask is, you can ask your doctor, and the question is, do I have a treatable biomarker? Am I a candidate for immunotherapy? Because if you are, then we can provide one of these treatment options, and guess what? You're much more likely to respond, and you're likely to do better. Okay, so make sure you get tested, especially if you have metastatic disease. All right, so there you go, you made it. So I really do hope you found this video helpful. If you did, consider subscribing, like, share. Guys, I'm constantly coming out with educational videos. My whole goal here is to help patients out. That's why I try to avoid medical terminology. I try to explain it as simple as possible, because my videos are for you, the patient. See you on the next one.